Hi, welcome to You and Your Health. I'm your host, David Bertone. Today's show is about one of the most important structures in your body, your feet. The foot is an area that handles a tremendous amount of pressure throughout the day, and we estimate you walk approximately 10,000 steps per day, and which causes significant amounts of problems to the feet and up the chain, the lower extremities, and to your back and other structures of your body. So we're going to learn today from an expert in the feet, and is Dr. Veronica Wolf. Dr. Wolf is a doctor of podiatric medicine and a graduate of the New York College of Podiatry and has a practice locally here in Homedale. Dr. Wolf, welcome to the show.
Oh, thank you very much. Thanks for having me.
So tell us a little bit about your background and how you got started in the field of podiatry.
Well, just to start off, I'm a Jersey girl, born and bred. Right. Always wanted to come back home. But I did go to New York College of Podiatric Medicine, graduated summa cum laude and as salutatorian of my class. Then my travels took me to residency up in North Jersey. It was a competitive foot and ankle surgical residency, and I served as chief resident my last year. Then I started practicing in Ocean County for a few years, up until I decided to have my own practice in Homedale, where I am currently.
Great. Now, give the audience a little background as to what is a podiatrist and what is a doctor of podiatry. There's a lot of terms for podiatry. There's some older terms, right? Some people called it a chiropodist.
That's right. That's right.
What is a podiatrist, and why would somebody go see a podiatrist?
Well, a podiatrist is a doctor of podiatric medicine. That's the degree we earn. Just like our allopathic, like MD or DO counterparts, we basically treat all the diseases of the foot, the ankle, and the lower leg. Mm-hmm. Just like MDs or DOs, we go to medical school and we go to residency. We need to be board certified. We take tests to become board certified. And then we need a medical license to practice. Okay. And our focus is the foot and ankle and every disease, whether treating it surgically or medically.
So anything below the knee is really
in the state of New Jersey, yes.
In the state of New Jersey,
mm-hmm.
Okay. So there are lots of conditions that people will see a podiatrist for, and we'll go through some of those. Let's talk a little bit about some preventative care things that you typically see on a routine basis, which you are concerned about as a podiatrist for some of the general population.
Well, preventative care is a big focus of my practice. You know, when I have a patient sitting in the chair, I generally look at their shoes, I look at what they're wearing. A lot of people underestimate what a good shoe, a good supportive shoe, what they can do for their feet to prevent things like ingrown toenails, blisters, calluses. And how it is with bunions and hammer toes. Those are common problems I see every day. Another big population I see are diabetic patients. Mm-hmm. Diabetes is a very aggressive disease that basically, a lot of people in the United States have now, with obesity on the rise. It's a disease that's pretty much on the rise. And these people have a lot of problems that show up in their feet first. Okay. So shoes that they wear, padding, things that we can offload any areas so that they can not get ulcers or any kind of trauma that can land them in the hospital.
Okay, so from a preventative standpoint, especially the diabetics, you are examining their feet routinely. Mm-hmm. How often do you see somebody like that with diabetes?
The American Diabetic Association recommends once a year that you see a podiatrist. Okay. But generally, when a patient has diabetes who's uncontrolled, meaning that their sugars are not at a nice even level, when they can have other diseases along with that, like peripheral vascular disease or poor circulation, there's somebody I might see a little bit more routinely, maybe about every 2 to 3 months. Okay. I'll check up on them, and we check their circulation, their muscle power, their skin, just looking for anything to prevent them having an issue that lands them in the hospital, and God forbid a amputation, which is the big thing that we're trying to prevent with the diabetic population.
Because a lot of times, I know in the diabetics, and we're focusing on that area, they have decreased sensation quite often from the diabetes. So they don't necessarily know if there's a problem on their foot, and they may step on something, and then it becomes a wound. And do you see quite a few?
Yes, I've seen quite a number of patients come in the office who don't even realize they have a piece of glass in their foot or even a needle, and they're shocked to see that when I point that out to them. We always advise, you know, prevention, you know, that an ounce of prevention is worth a pound of cure. You know, check your feet once a day if you have diabetes. Before you put your feet under the covers at night, just take a look at them.
Yeah.
If anything looks abnormal, you call your podiatrist, call your primary care doctor. Always wear, you know, good supportive shoes. You know, if you're trying to squeeze your foot, if you still think you're a size 6 and you're actually a size 9, that's probably not doing a good job for your feet. Also, you know, recommending trying not to walk around barefoot when you have diabetes, because you want to prevent from stepping on anything, any kind of something that's on the ground. Shaking out your shoes, making sure nothing fell in your shoe. I see that quite a bit. There's a stone or a rock in the shoe.
And they don't feel it.
No, and someone who has what's called neuropathy, that's when the nerves, they don't feel things in their feet when they have diabetes. And they just are walking around all day, that's rubbing against their foot. They can get a wound, a callus or a wound, or even worse, an infection.
Okay, now what about the nail care for this population, the toenails?
Yeah.
Is that a big issue?
Yes.
And some people, maybe, you know, cutting their toenails and such can cause problems. Do they need to see a professional in some of these cases?
I would. I mean, going by the American Diabetic Association, they just recommend you can see a podiatrist for things like routine nail cutting. It's checking on the nails when someone has diabetes and they don't feel their feet, or if they have what sometimes can go hand in hand with diabetes is poor circulation. If they accidentally cut their skin at the end of their toe and they don't realize it, they can get in pretty serious trouble with infection and later on possibly a hospitalization. So by seeing a podiatrist and having the podiatrist do that, who is, you know, of course, a better angle, a better view on the feet, and can safely cut the toenails and debride problems, there's something called debridement. Thinning out the nail. Some of these diabetics can get nail changes, thick yellow nails. They're more predisposed to fungal problems with the nails, or just in general thickening of the nail. So which can be hard to do with just your normal nail clipper at home. So to see a professional, which is something that we do all the time, and plus while you're there we can look at the skin, look to see if there's anything red or irritated that maybe the patient didn't realize, and prevent a problem.
Great. Now if somebody comes in and they do have a wound, that's another specialty, right? That you guys handle, like cleaning their wounds,
wound care.
We're trying to speed up the healing process.
Exactly. As a podiatrist, we do a lot of different things. We pull from a lot of different specialties and kind of all mash it into one when it comes to the foot and ankle. And also, like I said, wound care is a big part of it. If I have a patient come in, let's say for nail care, and then I see that there's an ulcer that maybe they didn't know was there, then I can start treating that wound. I can try to close it up, heal it up, so that they, like I said, no infection occurs. Or our goal as podiatrists usually are, you know, trying to avoid that hospitalization and trying to avoid amputation. So everything we can do, get the wound healed, maybe offload a bony, prominent area that seems to keep on breaking down. We'll do that. We'll do that with a change in shoes, with a change of padding in the shoe, and things like that.
Great. All right, let's move to another area that's very common is bunions.
Yes. Yes.
And obviously it's more prominent, I believe, in the females, but men do get bunions as well.
Yes, they do.
Right? So maybe you can just explain and show us on the model, what is it? What is a bunion?
A bunion is basically a malalignment. This is a foot model. This is the skeleton of the foot. You have your big toe, second, third, fourth, and your fifth toe. For some people at this big toe joint, and genetics has a big part to do with it, your heredity. You know, if you remember your mother, father's, grandmother's feet, odds are you may have the same copy of that. So the malalignment of the joint can be from genetics, but with the shoes you wear, you can't help it along and get worse. So what can happen is between the metatarsals, there can be a widening of the two metatarsals. And as time goes on, the big toe, because of the muscle pull, can just get pulled over. What happens is the joint starts to, you know, basically not function very well, and there's lots of grinding. You can get spurring at the end of the joint, and you get a big bump on the side of the foot, and which can be very painful. And especially if trying to find, for a larger bunion, trying to find a shoe to fit that is actually very difficult.
So hereditary is one risk factor. Shoe wear is another. Right? The type of shoes women that maybe wear tight,
very
shoe
narrow,
box is a risk factor. Is there anything else that kind of lends to that problem?
Well, flat foot, a very flexible flat foot, where a flat foot meaning where the arch is very low. You know, with the muscle pull, it tends to no longer be straight back on the toe, and the toe can be pulled over. So when wearing shoes, well, it goes back to shoes. It's all kind of interconnected.
Yep.
But when you're wearing shoes that are with no support, very flat on the inside with no middle raised arch in them, you know, over time, it just gets worse and worse. The muscle pull comes from the side, the toe keeps on going over. It's nothing that happens overnight. This is over years and years of trauma.
And that's one of the things during a preventative screening you may pick up.
Exactly.
And then may see that the person has a flat foot. You may want to order some things that would help with that we'll get into.
I see that with kids a lot.
Yeah.
You know, a lot of times, you know, kids can have flat feet. You get it from, you inherit it from your parents or, you know, from your family. And basically I say to the parents, I say, what can happen over years if they're not put into a good supportive shoe or even an arch support, something like this, to support their foot, you can prevent bunions and hammer toes from happening, from getting really bad, so that 20 years down the road they don't need surgery to correct these things.
Good,
and they're able to find shoes that fit them.
So now let's go a step further. Somebody has the bunion, they come in to see you. What is the treatment for that, and surgically, what is the procedure, and explain that to us.
Well, initially, education is a big part of my practice. I will get out the foot model, I will take x-rays, I will show the patient everything that's occurring, and so that they understand. And there's usually, I explain to them the conservative treatments for it. You know, if it's mild and it doesn't hurt them that much, they can get just a wider shoe. They could be perhaps wearing the wrong shoe size. I have a lot of patients that are wearing the wrong shoe size.
Okay.
And perhaps orthotics. Sometimes orthotics can help balance the foot out a little bit better, so that you decrease those forces that are deforming the foot, so that it doesn't get worse and lead on to more pain. Padding, something simple as, you know, there's things that you can get in the drugstore, little gel shields and little bunion straps that you can put on the toe that can kind of pad the area so that the shoe does not rub. But for some people, they try everything and nothing works. So they're usually the ones that go on to surgery. And surgery, it's usually a same-day surgery. It's not overnight in the hospital. And we have to actually break this joint to straighten it out.
Okay.
And then we get the toe to lie straight. And usually it takes about 6 to 8 weeks of healing. Some people are less, some people a little bit more. And depending on the procedure, there's a lot of different procedures that your podiatrist will tell you what exactly you need, depending on how bad the bunion is.
Okay. So that you're correcting the angle. You want to stabilize it in a new position somehow. Is there metal fixation? Is there pins sometimes?
It depends on the procedure that you're doing.
Okay.
Most of the time, what I use are screws.
Okay.
You don't have to worry about setting off the alarms in the airport. Okay. It never usually comes out. But, you know, sometimes some people use wires. There's different ways. And sometimes there's even absorbable fixation. Okay. You know, the patient will talk about it with the doctor. Sometimes it's doctor's preference. But you go and let the patient, you educate them on what's going on, and you discuss the options.
Okay. And then usually there's the recovery period, like you said, 6 weeks or so. And then you're trying to regain the normal mechanics of the foot.
Exactly.
Sometimes even I get to see those patients.
Yeah, I'm a big proponent of physical therapy. I try to get them into therapy as soon as possible, even with them actually moving their toe. We can't predict scar tissue, and we're actually trying to get them a better functioning foot when we do surgery. So if the scar tissue forms and is so tight that they lose function, then that's not good. So we try to have them work the joint, and then I send them to therapy and have them even work harder through physical therapy means to get as much range of motion out of the foot and as much strength back, because they are immobilized for a period of time afterwards. You do lose some strength, so you need to get that back, get your balance back. Plus, after surgery, things like orthotics, things like this, these arch supports are worn to help keep correction. Some people don't realize that those forces, the deforming forces that were in your foot to begin with, are still there. So God forbid 20 years from now, you have those, if you continue to wear ill-fitting shoes, non-supportive shoes, you can have that bunion come back.
So the surgical correction is important, the post-op rehabilitation, but then the follow-up to make sure it doesn't return, and then you have to have another procedure.
Exactly, and I always say that to my my peds patients, my kids. You know what I mean? Through training and things like that, I've seen, like, we're 20 years after a bunion surgery, they can come back only because they weren't put into proper shoes and things like that. It doesn't mean ugly shoes. It means just finding the right shoes. Each shoe has to be taken on its own merit.
Okay, so we've heard so far about some problems in the feet from Dr. Veronica Wolf. When we come back, we're going to hear some more specific diagnoses that she treats and some of the interventions that are necessary from a doctor of podiatric medicine.
Childproof caps don't work forever. Prescription drug abuse can kill. Talk to your teen.
Welcome back to You and Your Health. I'm your host, David Bertone. Our guest today is Dr. Veronica Wolf. Dr. Wolf is a doctor of podiatric medicine, and her practice is local here in Homedale, New Jersey. Dr. Wolf, thanks again for joining us.
Oh, thank you.
So we talked a little bit about some specific problems in the foot. We're going to move on and talk some more about things that are common for the population. How about hammer toes? That's another thing I hear quite a bit about.
Very common.
Okay.
It's usually, it comes down to the genetics again, but like I said, you can help things along with tight-fitting shoes, high-heeled shoes, big contributor to hammer toes. It's basically a muscle imbalance. You have tendons going to every toe and also little tiny muscles that are in between. And what can happen over years is that you get it's usually on the hand, it's an easier way to see. Instead of the toe being straight, your toe gets curved. And what can happen is shoes will rub right on that prominent joint, which leads to corns and calluses and pain. People can actually get an inflammation or a bursitis in that area, and where they actually feel like a thick fluid, a prominent fluid there, which continuously rubs. Okay.
And then what is the treatment for something like that?
Conservative would be, of course, padding, better shoes, making sure you're wearing the correct size shoes. Sometimes a square toe box instead of a pointy toe box, which means toe box just means the front end of the shoe. And also the front end of the shoe, meaning it has the toe box having a bigger height so that it can clear the height of the toe. For some people, when it's really severe, the toe can actually become so dislocated on the top of the foot that they can't find any shoes. So what we have to do is surgically correct that, which involves basically breaking this joint right here and resetting the toe. And it takes usually a few weeks, about 6 weeks or so to get better from that. Like I said, everybody's different. It depends on how severely contracted the toe is. And but for just a mild hammer toe, probably about 6 weeks, I'd say, to get better, to get back into a pair of sneakers.
Okay, so you're correcting the mechanics of the bone to release some of those soft tissues that are shortened? For
a severe for severe hammer toe, sometimes you have to go back to this is called the metatarsal phalangeal joint. It's where the long bone meets the toe. For severe problems, you'll have to release this joint because the toe is so completely contracted that even with doing a procedure at the tip of the toe, you still need to release it back and forth. And sometimes you actually need to break the metatarsal in order to get everything straight again. That would lead to a little bit more, a longer recovery time. Okay. And like I said, everybody's individual. And when a patient comes in, you take x-rays, we go over everything, and we figure out between the patient and the doctor, our team, figure out the best procedure for the patient. You mentioned the corns and calluses that develops because of a mechanical problem, I assume. Any bony prominence. And then what is the, I know you got to try to treat the underlying problem, but how do you immediately treat the corn and callus? What do you do about those? Usually when, over time, what can happen is it's a protective mechanism for your body. It continuously makes, a thick layer of skin. So the skin just thickens there. Exactly. Okay. It's a buildup of dead skin cells. And what we can do in the office to make it feel better is to debride it using either a scalpel or mechanically with the machine that we have to kind of smooth it down so that it feels better. Fortunately, there's no real cure unless you treat the underlying problem. The callus will always come back. You can slow it down, though, with certain pads in the shoes. They make some really great over-the-counter gel pads now, with orthotics as well. There's something that we can do with an orthotic right here. It might be hard to see. We can actually build dispersion pads into the orthotic so that it actually cushions the area so that the calluses come back slower, there's less pain. And some people, and actually activities as well, certain activities. I have a lot of patients that once they retire, they're not on their feet as much. The callus mysteriously disappears. So things like that. Great. Okay, let's move on and talk about gout. Okay. That seems to be a problem more, again, in men than women. And what is it that shows up in the feet when it comes to gout? Gout is a buildup of uric acid crystals. And for whatever reason, no one really knows why, it loves the big toe joint. But I've also seen it very commonly in the distal, or meaning the end of the toe joints as well. And people will wake up all of a sudden one day, red hot swollen joint. They didn't hit it against anything. They didn't fall, no trauma. They just woke up, and it's so painful. They always say the same thing. Even the sheet can't touch it. And usually have to go through their medical history. All right, there's a couple different reasons. Either well, for some people it used to be called the rich man's disease because they would eat a lot of heavy foods, wines, cheeses, alcohol, shellfish. For some people, they can have a buildup of this uric acid from the breakdown in their body. Some people, if they're kidneys, if they're not excreting it, then they have a problem. Or some people, medicines, hydrochlorothiazide, water pills sometimes can also, you get an imbalance and you get this gout. Buildup of crystals in the joint, your body sees it as a foreign body, you get red hot swelling around the joint. You can treat it with anti-inflammatories. Sometimes you can treat it with a medicine called colchicine. Sometimes with the steroid injection, you can treat it to kind of calm it down.
Great.
And I always send them to their doctor as well to get a full workup.
Make sure it's not other medical
Exactly. Some people need to be on a medicine, which can, if they make too much of it in their body, if they're an overproducer, there's a medicine they can be on to kind of calm it down.
Great. Let's move on to another common problem, plantar fasciitis, or heel pain, bottom of the foot pain.
Heel spur syndrome.
Heel spur.
Yep.
Can you just go through what that all means?
Sure, no problem. There's something called the plantar fascia. It's a very thick band of connective tissue that comes from the bottom of the heel bone, and this is called the calcaneus, and it spreads out to the ball of the foot. It's like a support strut for the arch. And for some people, it's usually people that stand a lot, and they can have a lot of stress to the area. Sometimes when they have flat foot, or even when they have a high arch called a cavus foot, they can have problems with this fascia. You have to realize when we stand all day long, the foot will flatten out, pulling on this fascia right at the heel bone. Plus, if you couple that with a very tight Achilles tendon, which is the big muscle on the back end of the leg that goes right into the back end of the heel bone, you have tightness here, tightness going there, and the heel is right in the middle of these two opposing forces. So people can all of a sudden, when they wake up in the morning, the first step is very painful, or when they sit for a while and they get up from a seated position, it can be an electric sharp pain coming from their heel. And for some people, it's very debilitating. Some of the common treatments are arch supports, basically balancing the foot out. Kind of like when you hurt your arm, you put a splint on it. The same thing with the fascia. If you fill in the area on the bottom of the foot, so the foot no longer collapses, the fascia has a chance to heal. Sometimes we start them on anti-inflammatory medicines, but a really big treatment is stretching. Once they, kind of get a little bit more limber and their Achilles tendon on the bottom of the foot, plus getting to a good pair of shoes and possibly supports, usually the pain will slowly go away. For some people, though, it becomes chronic. And weight is a big factor. If I have a lot of patients, they say, I put on a few pounds over, the years, and I've noticed that my heels are a lot more painful. So that's another common problem with it.
I quite often will see these patients as well, working on the soft tissues and getting the more flexibility, like you said, of the heel cord or the calf and this plantar fascia.
Right.
But then sometimes this underlying spur that develops.
Right.
Now, why do the spurs develop, and what are some of the treatments for the spurs?
For the spur, when you look at an x-ray, there's going to be, when you look at a side shot on an x-ray, you'll see off the heel bone, you don't see soft tissue, you won't see the plantar fascia on there, but what you'll see on the side shot of an x-ray is a little hook off the bottom end of the bone, which is actually where the plantar fascia inserts. And what I tell people is that just shows me there's a lot of stress in the area, that your fascia is constantly getting pulled and constantly undergoing a lot of force.
So bone grows in a direction of stress.
Exactly.
That's why they
It's called Wolf's Law.
Yep.
Exactly. But
you invented it, right?
Yeah, I wish. No. And what can happen over time is that you get this little hook off the bone. It can actually happen as well with the Achilles tendon.
Okay.
But that being said, there's also a nerve that runs right under that area. So when you have this constant pulling and these little micro tears that can happen right in that area of stress, it can be very painful. I have people that say, "Oh, it feels like it's connected to the back of my eyeball. It's so painful." So basically, what some people, when they don't get better with conservative treatments or even with physical therapy, a lot of my patients get better with physical therapy, I'm going to be honest with you. But for that small percentage that needs to go on to surgery, what we actually do is we go in there, we'll, that inside band of the tissue, we call it the medial band of the plantar fascia, we'll actually cut that band to kind of loosen it up, and then we'll go in and we'll try to file down that spur a little bit. And basically that's a surgical treatment. There's also another treatment called shockwave therapy, which is something that can be done in the office, and where sound waves are sent to try to break up adhesions and decrease inflammation, actually tell the body to start healing the inflammation.
Well, what are some of the studies that support things like that, shockwave therapy? Has that been shown to be
yes and no. It's been around, I would say, it's probably been around for about 10 years or so now. There are some studies, and people do get better with it, but it's a slow process. It's hard for patients. Not a lot of insurance companies cover it, so for you to say to a patient, go on to undergo this procedure, and then you have to wait like 3 to 6 months for you to start feeling better, it's kind of a hard sell.
It's a hard, yeah,
you
it's
know,
hard.
But for some patients it works well for, and it's a way to avoid the OR.
Got it.
You know, and just like any surgical procedure, there's no guarantees, because some people that actually go to the OR, some people feel better and some people don't. Like I said, big thing is shoes, the supports, and the stretching and the therapy.
Okay, good. Here's another condition that sometimes we hear of. A lot of people don't know it exists, but in the wrist we have something called a carpal tunnel.
Yep.
In the foot we have a
tarsal tunnel. Yep.
So can you explain what that is and what some of the things it may develop?
Oh, sure. I mean, on the inside part of your ankle, if you think of your wrist, it's very similar. You have a tight band of tissue, and right behind that there's very important nerves and a lot of ligaments, and right by that nerve there's 2 fat veins that follow right next to it. And for some people, especially flat-footed people, that their foot is rolling in, that nerve can get very irritated. And what can happen is they can have electric shocks that either shoot down their foot or up their leg. And it's so painful to walk on. Just like carpal tunnel syndrome and tarsal tunnel syndrome, we start, try to do things conservatively. First, we usually get them in an arch support to try to take the pressure off of that area. Sometimes injections work as well to try to decrease inflammation, and medicines. But for some people where nothing's working, we'll actually have to release that tight band of tissue and kind of free up the nerve. And actually sometimes we'll wrap the nerve with a special material to try to give it a little bit more room.
Okay, great. Quickly, let's talk about probably the most common thing you've seen is ankle sprains.
Yes, yes.
What happens in an ankle sprain?
When you have an ankle sprain, basically, there's a couple different types that can happen, but the most common is an inversion ankle sprain. Sometimes when you're stepping off a curb, or if you're in a high heel, there's not a lot of support for your ankle. So what can happen is your foot will turn in, and your rest of your body goes the other way. So there's 3 ligaments that are on the outside of your foot, and basically you have one in the front, one in the middle, and one in the back. And what can happen here is, especially with this front end, this is the anterior talar fibular ligament. When your foot turns in and this gets stretched, it can be very painful.
Lots of swelling and
lots
pain.
of swelling, bruising. People always think they break their foot. They don't realize that a sprain can be just as painful as a broken foot or a broken ankle. What I say to people is immediately either go to the ER or come to the office, and then I say let's get x-rays. For one thing, you have to make sure there's nothing broken. Treatment is usually standard. You rest it. Most people rest as wonders, icing it the first 24 to 48 hours, compressing with an ACE wrap at least, but sometimes we can actually do a little bit more, something called a Jones compression to decrease swelling, and elevating the foot. Great. Sometimes we give them crutches, and then we take it from there. The more severe ankle sprains, you kind of go further back, and you can actually tear these ligaments, then you might need a surgical correction.
Very good. Well, Dr. Wolf, thank you for joining us today.
Thank you very much. Thanks for having me.
Very nice having you.
Thank you.
Again, thanks for joining us on You and Your Health. I'm your host, David Bertone, and today you heard some exciting things about your feet and what you can do to prevent problems in the future.